You know that feeling, right? When you like smash your elbow on something? That awful, sharp, tingly pain.
Oh yeah, the funny bone. Not so funny.
Not funny at all. Or, maybe it's more like a dull headache that just won't let up. We've all felt pain.
Definitely. It's universal.
So today, on the deep dive, we're going beyond just, saying ouch. We're really getting under the hood, trying to understand what pain actually is.
Exactly. It's such a core part of being human, but how much do we really grasp about it? We've got some great material today, a pretty detailed pharmacology lesson plan, and also some really good insights from a pain clinic's YouTube channel.
Yeah, we've sifted through those.
And we're going to try and pull out the most important, maybe even surprising bits about this whole complex thing.
Right. Our mission here is to give you a clearer picture than just, it hurts. We want you to leave understanding a bit more about what's going on in your own body. So, okay, where do we even start?
Yeah.
What is pain, fundamentally?
Well, the first really striking thing is just how personal it is. One of our sources nailed it, saying, pain is whatever the person experiencing it says it is.
That's powerful.
Isn't it? It immediately validates everyone's individual experience. Your pain is real because you feel it. It deserves respect.
That makes so much sense, because what I might call a minor annoyance could genuinely floor someone else.
Exactly.
But is there a more maybe scientific definition that people generally agree on?
There is, yeah. The International Association for the Study of Pain, the ISP, they actually updated their definition pretty recently in 2020.
Okay, what do they say now?
They define pain as an unpleasant sensory and emotional experience associated with, or resembling that associated with, actual or potential tissue damage.
Okay. Unpleasant sensory and emotional experience. Both parts are key.
Absolutely. And that phrase, or resembling that associated with,
Yeah.
that's really significant too.
Yeah, I caught that. It sounds like you can have pain even without obvious physical damage.
Precisely. And the IASP unpacks this further with some crucial points. They stress that pain is always personal, shaped by biology, psychology, and social factors. It's not just one thing.
A mix of everything.
Yeah. And here's something interesting. Pain isn't the same as nociception.
Nociception. What's that again?
That's the nervous system's process of encoding harmful stimuli, basically the danger signals being detected. The ISP says these two are distinct. You can have those danger signals firing without feeling pain, or feel pain without any clear tissue damage sending signals.
Wow. Okay, so it's not just a simple wire from, say, my stubbed toe street to a pain light in my brain.
Not at all. Your brain is actively interpreting and, in a way, constructing that experience.
Wow.
The IASP also notes we actually learn the concept of pain through our lives. It's not purely instinctual.
We learn it. How so?
Through experiences, observations, And critically, they state that a person's report of pain should be respected. Full stop.
So if someone says they hurt, believe them, even if tests don't show anything obvious.
Exactly. And they also mention that pain usually serves a purpose, like a warning system.
Right, like touching a hot stove.
But it can also turn negative, affecting well-being and function, especially when it becomes chronic.
That makes sense.
And finally, a really important point. Just because someone can't verbalize their pain, maybe an infant, or someone with a communication disorder, doesn't mean they aren't experiencing it.
That's crucial for caregivers. It sounds like our understanding has shifted quite a bit over time. You mentioned the sources referenced an older definition from 2001.
Yeah, the main difference seems to be that the older definition focused more heavily on that direct link to tissue damage.
Okay.
The 2020 update really broadens the lens to formally include those emotional, psychological, and social dimensions. It recognizes pain as a much more holistic experience.
Okay, so pain is complex, personal, emotional.
Yeah.
Got it. But what's actually happening inside our bodies? Let's get into the mechanics, the physiology.
Right, the nuts and bolts. So yeah, pain is this incredibly intricate, multidimensional thing involving senses, emotions, thoughts, even behavior. It typically starts where the trouble is, so to speak.
Walk us through that sequence. What's the first thing that happens?
So the first step is called transduction. This is where some kind of noxious or harmful stimulus, maybe intense heat, pressure, or chemicals released from injured cells activate specialized nerve endings. These are called nociceptors.
Nociceptors, like little pain detectors?
Pretty much, yeah. They're like tiny alarm bells in your skin, joints, muscles, organs. When they get triggered, they release a cocktail of chemicals, things like bradykinin, prostaglandins, histamine.
Ah, so those sound familiar from inflammation.
Exactly. They're often involved in both. These chemicals then stimulate the nociceptors, converting that initial harmful event into an electrical signal.
Okay, so the alarm's been sounded electrically. What's next?
Next is transmission. That electrical signal needs to travel. It zips along peripheral nerves, heading towards the spinal cord.
The spinal cord, kind of like the central highway for nerve signals.
That's a good way to put it. It's a major relay station. From the spinal cord, the signals then shoot up towards the brain.
And then the brain gets the message.
Right. Which brings us to step 3, perception. This is where the brain becomes consciously aware of the signal and interprets it as pain. But it's not just a passive receiver.
How so?
The brain actively processes it, filtering it through like past experiences, your current mood, your focus. All sorts of things influence how you actually perceive that pain.
So my brain is like the editor, deciding how much attention to give the pain signal and what it means.
In a way, yes. And there's one more step, which is fascinating. Modulation.
Modulation, like adjusting the volume.
Kind of. It's our body's own ability to turn the pain signal up or down. We actually produce our own natural pain-relieving chemicals.
Really? Like what?
Endogenous opioids you might have heard of, endorphins, and enkephalins too, plus other neurotransmitters like serotonin and norepinephrine. These can inhibit or block pain signals traveling to the brain.
Wow, so our body has its own built-in pain control system. That's pretty amazing.
It really is.
Now, the sources also mention different types of nerve fibers, A delta, C, and A beta. What roles do they play?
Right. These are the different wires carrying the signals. They vary in speed and what kind of sensation they transmit. Delta fibers are relatively fast. They have a fatty coating called myelin, which acts like insulation and speeds up the signal.
Okay, fast ones. What do they carry?
They're responsible for that first, sharp, well-localized acute pain. Think of the immediate sting from a paper cut or stepping on something sharp, that initial ouch.
Got it. The immediate warning. What about the C fibers?
C fibers are slower. They're unmyelinated, so the signal travels more sluggishly. They typically carry the signals for that duller, throbbing, burning, or aching pain that often follows the initial sharp sensation, the lingering hurt.
Ah, okay. So A delta is the sprint, C fiber is the marathon of pain signals.
Yeah, something like that.
And then there were A beta fibers. They sounded different.
They are different. A beta fibers are large and myelinated, so they're fast too, but they mainly respond to non-painful stimuli, things like light touch, pressure, vibration. And interestingly, they can actually help reduce pain perception.
Reduce it? How? This sounds like it connects to that gate control theory the sources mentioned.
Exactly. You're anticipating the next point. The gate control theory, which was a landmark idea from Melzack and Wall, proposes that there's sort of a gate mechanism in the spinal cord in a specific area called the dorsal horn.
A gate, like letting things through or stopping them.
Precisely.
Yeah.
It can control the flow of pain signals heading up to the brain. Think of it like a neurological checkpoint.
Okay, intriguing. So how do these different fibers affect the gate?
Well, the theory goes that activity in those pain-signaling fibers, the A delta and C fibers, tends to open the gate, allowing more pain signals to pass through to the brain.
Makes sense. More pain signals, more pain felt.
But activity in the large A beta fibers, the ones carrying touch and pressure signals, can actually help to close the gate.
Close the gate.
Yeah.
So less pain gets through.
Exactly. By stimulating A beta fibers, you can essentially inhibit the transmission of pain signals from the A delta and C fibers at that spinal cord level.
Ah, so that's why rubbing a bumped elbow or putting pressure on a bruise actually feels like it helps.
That's the principle in action. You're activating those A beta fibers and helping to close the pain gate.
That is genuinely fascinating. Simple actions having a real neurological effect.
It is. And the theory also incorporates the influence of our brain and psychological state. Things like anxiety, fear, or focusing on the pain can actually send signals down from the brain that open the gate wider.
Making the pain feel worse.
Right. Whereas relaxation, distraction, feeling in control, these can send signals down that help close the gate.
Wow. Mind over matter, to some extent. It really shows that powerful link between our thoughts, emotions, and physical sensations.
Absolutely. It was a revolutionary idea because it highlighted that pain isn't just a one-way street from injury to brain.
Okay, this is all painting a much richer picture. Let's shift now to how we categorize pain. The notes mention classifying it by duration and by source.
That's right. It helps clinicians understand and treat it better. So first, by duration. The main categories are acute and chronic pain.
Acute is the short-term kind.
Yeah, generally. Acute pain typically lasts less than 3 months. It usually has a clear cause like surgery, an injury, a burn, and it generally resolves as the underlying tissue heals.
Like a sprained ankle pain that goes away after a few weeks.
Exactly. Then there's chronic pain. This is pain that persists for longer than 3 months.
3 months now? I thought it used to be 6.
It did, yeah. The time frame has generally shifted to 3 months in many definitions now. It reflects a better understanding that persistent pain, even after just 3 months, can have significant impacts and might need different management.
Okay. And chronic pain doesn't always have an obvious cause, right?
Sometimes it does, starting from an initial injury but just not resolving. Other times, like with conditions such as fibromyalgia or some types of back pain, the original trigger might be unclear, or the pain mechanisms themselves have changed. It just hangs around.
That nagging, persistent kind. Okay, so that's duration. What about classifying pain by its source?
Right. Where's the pain signal actually originating? One type is somatic pain. This comes from the body tissues, skin, muscles, joints, bones. It's usually fairly easy to pinpoint.
Like a cut on your finger or a pulled muscle in your leg? You know exactly where it is.
Precisely. Well localized. Then there's visceral pain.
Visceral. Sounds like organs.
Exactly. This originates from our internal organs, the viscera. Think abdomen, chest. This type of pain is often much harder to localize. It might be felt as a deep ache, pressure, cramping, or squeezing.
Like indigestion pain. Or maybe something more serious, like appendicitis. You feel it generally in the area, but it's vague.
Yeah, often diffuse and poorly localized. Then we have neuropathic pain.
Neuropathic, so nerve pathway pain.
You got it. This pain arises from damage or dysfunction within the nervous system itself, either peripheral nerves or even the central nervous system. The nerves themselves are the source of the pain signals.
And this feels different.
Very different, often. People describe it using words like burning, shooting, stabbing, tingling, numbness, or like an electric shock. Think of diabetic neuropathy or post-herpetic neuralgia after shingles.
And you mentioned earlier that standard painkillers might not work well for this.
That's a crucial point. Medications that work for somatic or visceral pain often aren't very effective for neuropathic pain. It frequently requires different classes of drugs, sometimes called adjuvants or anti-nerve pain medications.
Good to know. What else? Referred pain was mentioned. That sounds counterintuitive.
It is a bit strange. Referred pain is pain that's felt in a location different from where the actual tissue damage or problem is occurring.
How does that happen?
It's thought to be due to the way nerve pathways converge in the spinal cord. Signals from an internal organ, for example, might enter the spinal cord at the same level as signals from a patch of skin, and the brain gets confused about the origin.
So the classic example is
Left arm or jaw pain during a heart attack. The problem is in the heart, but the pain is perceived elsewhere because those nerve pathways overlap somewhere along the line.
fascinating and definitely important clinically.
Very. And the last type mentioned in our sources is phantom pain.
Pain in a limb that isn't there anymore.
Exactly. After an amputation, many people experience sensations, including pain, that feel like they're coming from the missing limb. It's a real, often distressing phenomenon.
It really highlights how much the brain contributes to our body map and pain experience.
Absolutely. It shows pain isn't just about signals from the periphery. The brain's interpretation is paramount.
Okay, so many ways pain can manifest. Now let's talk solutions, or at least management. The notes covered both non-drug and drug approaches. Let's start with non-pharmacologic strategies.
Right. These are really important tools, often used alongside or sometimes even instead of medications. They tap into some of the mechanisms we've discussed.
Like massage. We mentioned that with the gate control theory.
Exactly. Massage stimulates those A-beta fibers, potentially helping to close the gate to pain signals. Simple touch can do this too.
Makes sense. What about heat and cold? The classic remedies.
They work differently. Heat therapy causes vasodilation, widening blood vessels, which can increase blood flow, relax muscles, and ease stiffness. Cold therapy causes vasoconstriction, narrowing blood vessels, which can reduce inflammation, swelling, and numb the area, slowing nerve conduction.
So they have distinct physiological effects. What else is in the non-drug toolkit?
Lots of things. Relaxation techniques, deep breathing, meditation, progressive muscle relaxation can reduce muscle tension and also calm the nervous system, potentially helping close that pain gate via descending pathways from the brain.
And distraction. Does just thinking about something else really work?
It can, yes. By engaging your attention elsewhere, you're dedicating fewer cognitive resources to processing the pain signals. It doesn't make the signal disappear, but it can reduce the perception of pain.
Interesting. Acupuncture was mentioned too.
Yeah, acupuncture involves inserting fine needles at specific points. The exact mechanisms are still debated, but one prominent theory is that it stimulates the release of endogenous opioids, those natural painkillers, like endorphins.
Our body's own pharmacy again.
Right. And then there are 10 NS units, transcutaneous electrical nerve stimulation.
Those little machines with sticky pads.
Those are the ones. They deliver mild electrical currents through the skin. The idea is often related to the gate control theory, stimulating those A-beta fibers or potentially triggering endorphin release as well.
So quite a range of options there, targeting different aspects of the pain experience.
Definitely. And they empower patients to take an active role, which is also really important.
Okay, now let's move on to the pharmacologic side, the medications used for pain.
Right. The choice of medication really hinges on the type and severity of the pain. For mild to moderate pain, particularly if there's inflammation involved, the first line is often non-opioid analgesics.
Likely.
Acetaminophen, that's Tylenol, and NSAIDs, which stands for non-steroidal anti-inflammatory drugs. Common examples are ibuprofen, Advil, Motrin, and naproxen, Alay.
What's the main thing to watch out for with those?
Well, NSAIDs can be tough on the stomach lining, potentially causing irritation, ulcers, or bleeding, especially with long-term use. Acetaminophen is generally easier on the stomach, but taking too much can damage the liver, so dosage is key.
The pain clinic videos mentioned COX-2 inhibitors. Are they a type of NSAA?
Yes, they are. Drugs like celecoxib and etorcoxib, they were developed to target inflammation more specifically while having potentially fewer gastrointestinal side effects than traditional NSAIDs. But they aren't without their own potential risks, so it's always a discussion with the doctor.
And the clinic also suggested taking regular NSAIDs with an antacid sometimes.
Yeah, for people prone to stomach upset, a doctor might recommend taking an antacid or another stomach-protecting medication alongside the NSAID to minimize irritation.
Okay. What if the pain is more severe than what these can handle?
Then we move up the ladder, often to opioids. These are medications like morphine, oxycodone, hydrocodone, codeine. They work primarily in the central nervous system to block pain signals and are generally used for moderate to severe pain.
And these are the ones that need careful management.
Absolutely. They are effective, but they come with significant risks and side effects. Sedation, respiratory depression, slowed breathing, constipation are common ones. There's also the potential for tolerance, dependence, and addiction, so they require very careful prescribing and monitoring.
Right. Now, the notes also listed adjuvant medications. What role do they play?
Adjuvants are interesting. They're drugs that have primary uses other than pain relief, but have been found to be effective for certain types of pain, especially neuropathic pain.
Ah, so these are the anti-nerve pain drugs we talked about earlier.
Exactly. Things like certain antidepressants, amitriptyline is a classic example, and anticonvulsants, like gabapentin or pregabalin. They seem to work by calming down overactive or damaged nerves.
Because the regular painkillers often don't cut it for nerve pain.
Precisely. Common side effects for these can include drowsiness and dizziness, so dosage usually starts low and increases gradually.
Okay. What about things you put on the skin? Topical agents.
Yeah. Things like lidocaine patches or capsaicin cream. Lidocaine is a local anesthetic. It numbs the area where you apply the patch. Capsaicin, derived from chili peppers, works in a more complex way, eventually depleting a chemical involved in sending pain signals from nerve endings.
So they provide localized relief. Any downsides?
Mainly potential skin irritation at the application site for some people.
And lastly, corticosteroids were mentioned, like prednisone.
Yes. Drugs like dexamethasone or prednisone, these are powerful anti-inflammatory medications. They're not typically used for general pain relief, but can be very effective when severe inflammation is a major component of the pain.
But they have side effects too, right?
They do, especially with long-term use. They can affect blood sugar, increase infection risk, cause mood changes, thin the skin, weaken bones. So they're usually used for specific conditions and often for shorter durations or at the lowest effective dose.
It's definitely a complex landscape of medications. How do doctors navigate this? The WHO analgesic ladder came up in our sources.
Right, the WHO analgesic ladder. It was originally designed back in the 80s, primarily to guide the treatment of cancer pain, but its principles are often applied more broadly now. It's a framework.
A step-by-step approach.
Essentially, yes. It suggests starting with simpler, less potent medications and escalating only if the pain isn't controlled. The original ladder had 3 steps.
Okay, what were they?
Step 1 for mild pain was using non-opioids like acetaminophen or NSAIDs, potentially with an adjuvant medication if appropriate.
Makes sense. Start simple.
Step 2 for moderate pain or pain persisting despite Step 1 involved adding a so-called weak opioid like codeine or tramadol, typically still alongside the non-opioid and maybe an adjuvant.
Okay, adding a bit more power.
And Step 3 for severe pain or pain persisting despite Step 2 involved switching to a strong opioid like morphine or oxycodone, again, usually continuing the non-opioid and any necessary adjuvants.
So a clear progression based on severity. You mentioned our sources noted a shift to a 4-step model sometimes.
Yes, some adaptations or newer interpretations include a 4th step. This isn't universally adopted in the same way, but the idea is to incorporate more advanced options for complex or refractory pain that doesn't respond well to the first 3 steps.
What kind of options are in this 4th step?
This step often brings in interventional therapies, things like nerve blocks, spinal cord stimulators, radiofrequency ablation, maybe intrathecal drug delivery. These might be combined with ongoing medications, possibly including strong opioids or other combinations from the earlier steps, plus adjuvants.
So it acknowledges that some pain needs highly specialized approaches beyond just oral or patch medications.
Exactly. It adds another layer for those really challenging cases, but the core principles of the latter remain important.
What are those key takeaways from the latter approach?
Well, first, it's a guideline, not rigid rules. Treatment always needs to be individualized. Second, it emphasizes starting simple and escalating logically. Third, non-pharmacological therapies should be considered at every step. It's not just about drugs.
Holistic approach.
Yes. And fourth, the overall goal is achieving adequate pain control while minimizing side effects, particularly aiming for the lowest effective opioid dose for the shortest necessary duration, if opioids are needed at all.
That makes a lot of sense, balancing effectiveness with safety. Finally, let's touch on the role of nurses. Our sources highlighted their importance in pain management.
Absolutely critical. Nurses are often the ones spending the most time with patients and are really on the front lines of assessing and managing pain.
What does that assessment involve?
It's comprehensive. They ask about the pain's location, intensity, often using standardized scales.
Like the 0 to 10 scale.
Exactly, the numeric rating scale, or the Wong-Baker-Faces scale, especially useful for kids or those with communication difficulties. They also ask about the quality of the pain. Is it sharp, dull, burning, aching? Its duration, what makes it better or worse?
The whole picture.
Right. There's often a mnemonic used, like OPQRST onset, provoking palliating factors, quality, region radiation, severity, timing. It helps ensure nothing is missed.
So a thorough investigation, not just a quick question.
Definitely. An assessment doesn't stop there. A key nursing responsibility is reassessment. They need to check back after giving medication or trying a non-drug intervention to see if it worked.
Did the pain level change? Are there side effects?
Precisely. Monitoring effectiveness and watching for adverse reactions is crucial. Nurses also play a huge role in patient education, explaining the pain management plan, how medications work, potential side effects, the importance of non-drug strategies. This empowers patients.
And that empowerment can even help manage the pain itself.
It really can. Feeling informed and involved can reduce anxiety, which, as we know from the gate control theory, can influence pain perception. Education might even increase someone's pain threshold, paradoxically.
Interesting.
And finally, nurses are vital patient advocates. They communicate the patient's pain experience to the rest of the healthcare team and advocate for appropriate and timely pain relief. It's a fundamental part of their role.
It sounds like a really dynamic and essential contribution to patient comfort and care.
Well, this has been quite the journey into understanding pain.
It really has. We've covered a lot, from the basic definition, how personal and complex it is, through the body's intricate signaling pathways.
The different types, gate control.
All the way to the various management strategies, both non-drug and medications, and the guidelines like the WHO ladder.
Yeah. Hopefully for you listening, this deep dive has maybe demystified pain a little bit, or at least given you a richer appreciation for what's involved. It's so much more than just that raw sensation.
Absolutely. It's this blend of biology, psychology, and even our social context. So maybe a final thought to leave you with. Considering everything we've talked about, the mind-body connection, the emotional component, the different types of pain, how might looking at your own experiences with discomfort, even minor aches, through this more holistic lens, how might that change how you approach self-care or how you talk about pain with your doctor?
That's a great question. Something beyond just saying it hurts, perhaps.
Exactly. Something to think about.